Hello everyone and welcome. Before we start, I'd like to acknowledge the traditional custodians of the lands on which we all meet today and pay my respect to their elders past and present, and we extend that respect to Aboriginal and Torres Strait Islander people joining us online today. Aboriginal and Torres Strait Islander peoples were the nation's first scientists, and they remain the spiritual and cultural custodians of their land. Welcome everybody. My name's Professor Kathy Sherrington. We're delighted that you've all joined us today. For many, perhaps your first step towards embarking on a career combining clinical practice with research. Perhaps some of you are already on this journey and looking for advice. Perhaps some of you are not quite sure yet exactly what you want to do, but you've all committed the time to join us today. And we hope that we live up to expectations and can provide a useful session. The Life as a Clinician-Scientist Symposia are an initiative of the Australian Academy of Health and Medical Sciences, of which I am a fellow, along with some of my co-chair, Professor Kim Burnell, and the two key speakers as well. This event fulfills the Academy's objective of nurturing our country's future research leaders and advancing health and medical research for the benefits of all Australians. And we're very grateful to have a number of fantastic clinician scientists joining us today, and we're incredibly grateful for them giving up their time. And this is the first time that we've actually had a multidisciplinary initiative. And so we hope that we can all learn a lot from each other and leave the session feeling inspired. So today's full program, including the speaker bios, is available online and could be accessed using the QR code on the screen. And so we'll have the two keynote speakers followed by a panel discussion. And so there'll be the option to ask questions of the speakers, but you might need to, that's fine. I would just like to acknowledge the platinum partners of the Academy. So this event wouldn't be possible without their generosity. So Deakin University, the Murdoch Children's Research Institute, the George Institute, Centenary Institute, the University of Melbourne, UNSW Sydney, and the University of Sydney. And we're also extremely grateful to the Academy's Gold partners and also program supporters from around the country. And these are all organisations who are invested in the future of Australian health and medical research. We just wanted to give you a little bit of background about the Academy. So the Academy is one of 5 learned academies in Australia, and these all aim to be impartial and authoritative voices for science and our Academy for Health and Medical Science in Australia. We have 529 fellows, and these are from a range of disciplines and are really the best and brightest minds in the field of medical and health sciences. And they've all been elected for outstanding achievements and exceptional contributions to the sector. And we're uniquely positioned to really bring together stakeholders from different sectors in this way. And so the Academy does this by celebrating and strengthening research, influencing policy, supporting Aboriginal and Torres Strait Islander health and wellbeing, and aiming to build the interface between health, academia and industry, and also crucially nurturing future research leaders such as yourselves through mentorship programs, initiatives and events such as this. And these Life as a Clinician Scientist program, the program itself is now in its 10th year, and so far there's actually been 200 speakers sharing their wisdom over 34 events around the country. and online. We also are recording the presentations today, and these, along with 150 other videos, will be available on the Academy's YouTube channel in coming weeks. And if you haven't already, please consider joining the Academy's mailing list so that you can stay up to date with news and opportunities in the sector. So it now gives me great pleasure to be introducing our first keynote speaker, Professor Rochelle Bookbinder AO. Professor Bookbinder is a rheumatologist and clinical epidemiologist, an NHMRC investigator fellow, and head of the musculoskeletal health and wiser healthcare units at Monash University. Professor Bookbinder is also the co-founder of Wiser Healthcare, which is a national collaboration that aims to reduce overdiagnosis and overtreatment, and is known. Professor Bookbinder is known for her landmark studies examining treatments that have been accepted into practice before proper evaluation. So please join me in welcoming Professor Bookbinder.
Thanks very much, Kathy, for that introduction. I'll just share my slides.
Perfect now.
Okay, thanks, Kathy. So I'm going to talk today about 5, I guess, key things that have happened in my career. I'm going to talk about public health messaging to improve care for people with back pain, trials to establish the true benefits of treatment, optimising the quality of healthcare and in particular reducing low-value care, collaborations and partnerships to improve health, and raising public awareness about the problem of too much medicine. Before I begin, a little bit about me. So I studied medicine at Monash University and at Prince Henry's Hospital, completing in 1981. I did my residency at both at the Alfred and then rheumatology training in Prince Henry's and the Alfred, completing that in 1989. I married a man from my medical year who's now a medical oncologist at Peter MacCallum, but he was a resident like me at the time that we got married. And we had our first son, Adam, in 1988. And then in 1990, we went overseas to do I did a clinical fellowship at the Wellesley Hospital in Toronto, and I did a Masters of Clinical Epidemiology as well. While we were there, that's me pregnant with Adam, and we had our second son, Noah, on Canada Day, born in Canada with a Canadian passport. And before returning to Australia in 1993, where I started in private rheumatology practice, and pleasingly, my eldest son, Adam, is in practice with me and will be taking the practice over very shortly. I've been in the School of Public Health and Preventive Medicine at Monash since I returned, and I've been really fortunate to have continuous NHMRC support, including fellowship support, since 2002. I actually did my PhD retrospectively in 2006 by publication, and it was the evaluation of the public health campaign that I'm going to talk to you about. I was at Cabrini Hospital and set up their clinical epidemiology unit, which is no longer in being, and I still enjoy doing private practice and working as a clinician academic scientist. We had our third son in 1995, and he's now actually a resident at the Alfred in third year, hoping to do anaesthetics. So the public health campaign I was asked to evaluate is Back Pain, Don't Take It Lying Down. It was established in 1997 by the Victorian Work Cover Authority that back pain costs had tripled over a decade and weren't getting any better, and there was nothing seemingly that could be done to reverse this. So they decided, based on the fact that in Australia we have very successful public health campaigns, that they would do a public health campaign for back pain. And it was very focused on very simple messages that haven't really changed today about the best way of treating back pain. That is staying active, not resting for prolonged periods, remaining at work, and most people do not need imaging of any sort. It was primarily television ads, and that's Merv Hughes of Cricket Frame in the picture above. And these were aired during primetime television because that was possible at that time. The Black Book, which is a simple publication for patients, was published in 16 languages, and there were compensable back pain guidelines. And I was asked to evaluate this campaign. And so the first thing we did was look at population beliefs, and we looked at beliefs before the campaign started, both in New South Wales and Victoria, excluding people living on the border who might be exposed to Victorian television. And what this slide shows is that there was a dramatic improvement in back beliefs in Victoria, with no change in New South Wales over time. And so New South Wales was our control state. Not only, and similar, an important aspect of population campaign is that it reaches people who are difficult to reach, so people with poorer beliefs as well as people with better beliefs to begin with. And this shows quantile plots, which plot the changes over time in the distribution of the back belief scores and the fear avoidance belief scores over time. And what you can see in survey 1 is that the beliefs in Victoria and New South Wales were identical. But over the course of the campaign, the distribution of beliefs improved in Victoria, starting in the middle, and then in survey 3, you can see well in the middle. And then by the end of the campaign, people with poorer beliefs down the bottom of the graph also improved. And that's a characteristic of public health campaigns. Their fear avoidance also reduced in Victoria, and this happened irrespective of where they started. We didn't just change population beliefs, we also changed doctors' knowledge and beliefs, and that's another advantage of a mass media campaign, is that you change the beliefs of everybody irrespective of whether you see the campaign or you don't see the campaign. And by the end of the campaign, Victorian doctors were much more likely to know that people didn't need to rest in bed, they didn't need to stay home from work, and they didn't need imaging. There was only one group of doctors who did not improve as a result of the mass media campaign, and I asked you to hazard a guess who they were. And so the only group that didn't change were doctors who had a special interest in back pain. They didn't change their attitudes and beliefs. They still thought patients needed imaging, they needed rest, they needed to stay away from work. And so the takeaway from this slide is that if you have back pain, don't see someone with a special interest in back pain. So moving on from the public health campaign, which was really my first big project when I returned to Australia. And this finally, not only did we change doctors' beliefs and patient beliefs, we also significantly reduced the number of people who went off from work for back pain, the duration of the time that they were off work, the cost of their medical costs, as well as their absolute costs. And so this was a really dramatic campaign, and it's now been replicated in many other settings, and in places like Canada, it continues to this day. The second big thing that I've done in my career is to do clinical trials to try and establish the true benefits of treatment. And one of the big trials that we did was looking at vertebroplasty, which is a type of bone cement that was being injected into people with vertebral fractures. It had been in use for over a decade without a single placebo-controlled trial, not even actually a trial. There were no trials when we started this study. And what we found is that, in fact, vertebroplasty provided no benefit over placebo, but it has potential for many serious harms, including death. And so vertebroplasty went from being a treatment that enables the bedbound to walk again, which was how it was described in the Telegraph, to the poster child for their systemic failure to perform the appropriate evaluation of invasive procedures before they are widely accepted. And so this really started me on a journey to look for other treatments that have been already accepted into practice, but we have no high quality evidence that they actually work. And so over my career now, we've looked at many treatments, both either as in trials or systematic reviews. And on the left here are all the treatments that we've studied, which we should stop doing today. But unfortunately, many of these things continue because we've already shown that there are no benefits over placebo, but there are potential for harm. I have been fortunate in finding a few treatments that do work, and they're shown on the right. And we're still doing trials for the ones in orange down the bottom. So it's really important to think about whether treatments really work. And in fact, we know that about 60% of what we do is effective, and about 30% is ineffective, and another 10% of what we do is actually harmful. The other thing to demonstrate from this slide is that I haven't just stayed in my lane of rheumatology, but I've been interacting with radiologists to do the vertebroplasty trial, surgeons and physiotherapists to do many of the other studies that I've been involved with over the years. The next thing I want to talk about is a partnership that we have with the Department of Health and Aged Care. And we set about during COVID to try and reduce low value imaging for people with musculoskeletal conditions. And what we did was that we identified the top 20% of GPs who'd been overusing the tests that you can see there. So X-rays, CTs, MRs, ultrasounds of various regional sites in the body, for which most people don't need imaging when they present with back pain, neck pain, shoulder pain. And we randomized practices into 5 groups. One group got no intervention, and the other groups got an audit and feedback letter. So we sent them their results compared to their peers for how many tests that they'd been ordered. And we also sent some of them the letters twice, and for some people got a more enhanced feedback display. And what we showed is that just this very simple audit and feedback letter that wasn't, that was in a very positive sense and sort of educational letter about how people should be thinking about imaging and thinking twice about imaging. What we found was that we could reduce our scans by 47,000. That was within 6 months, saving the MBS about $9 million. So this is a very effective way of trying to improve care for people with musculoskeletal conditions. In terms of other collaborations, I co-founded in 2015 the Australian-New Zealand Musculoskeletal Clinical Trial Network. And we've been really fortunate to be awarded CREs, and we're currently in our 2nd CRE. And we started with about 100 trialists. We now have over 400. And I was very pleased and proud to know that we've been dramatically increasing capacity to do trials in my field. We've funded quite a few PhDs and postdocs. And now we're doing more ambitious things like an online musculoskeletal trial course and complex studies. As Kathy mentioned, I'm also co-founded the Wiser Healthcare, which is really conducting research to reduce overdiagnosis and overtreatment both in Australia and around the world. And again, I'm lucky and fortunate to work with a wide group of people who were physios, psychologists, epidemiologists, just to name a few that I work with to, again, reduce this problem of too much healthcare. And finally, with Ian Harris, who's an orthopaedic surgeon, we published a book in 2021 that was really raising public awareness about the problem of too much medicine. The book is based around the Hippocratic Oath and all the things that we're doing wrong, and then some things about how we might address the problem. And we were really fortunate to have a writing residency in the Rockefeller Centre in Villaggio, Italy. And that's a photo of Ian when we arrived in Villaggio to start writing our book, which we wrote over 4 weeks in 2018. On the right there, you can see some of my team. Again, we're very multidisciplinary. We have a consumer-led researcher. We have an epidemiologist, health economist, biostatistician, physiotherapists, research assistants, implementation scientists, and other rheumatologists. So we work with many people to try and improve healthcare for people with not just musculoskeletal conditions, but really all conditions. And I'll stop there. Thank you.
Thank you so much, Rochelle. That was amazing. And as a physiotherapist myself, and having a number of colleagues who have worked with you, I can really attest to the multidisciplinary importance of your work and the impact that you've had, and how we can genuinely make a bigger difference by working together. So yeah, congratulations. We've had a couple of questions come through. So yeah, just encouraging people to use the Q&A through Slido. One of them is for you, Rochelle, initially. So how can a clinician-scientist effectively promote their research within their peer community?
I guess that's a hard question, but it's by any means that you can, I guess. So you can try and publish your work, and if you publish it in the journal where most people who need to see it will read it, that's really important. So I much more think about who the audience is when I think about where I'm going to publish an article, rather than just go to the top journals. But I want to know, is it an Australian audience? Is it an international audience? Who needs to hear this message? There are talks, so giving presentations, getting your abstracts accepted, and also I think increasingly working with patients and consumers and getting them to deliver your message, I think is another way that increasingly I can see as a way forward.
Fantastic, great answer. The next two are actually more about the sort of practice of being a clinician scientist. The first one is about having had exposure to the different challenges of sort of clinical and research settings. Do you think that being involved with both actually helps one resist burnout? Like having those kind of different settings and kind of different challenges and bureaucracies?
For sure. I mean, I've always combined it. I remember when I came back from overseas, the head of the school at that time wanted me to be a full-time researcher, and I really just resisted that, because I love seeing patients, and patients really were the ones that gave me my questions in the beginning. So I think it's really important to do both, and I get a lot of satisfaction and value from doing both. And I think it does reduce burnout. You can have a really good day in the clinic and feel good, and you can not get your grant and feel really rotten. So seeing patients cheers you up, and vice versa. You can have a really bad day in the clinic and get a grant. So there, I think the balance is really important, and I like to do lots of things at the same time.
Amazing. And now another anonymous questioner has spotted that you've also raised kids, and very successfully by the sound of it, and asks if you've got any suggestions for that juggle between clinical work, research and family life.
I think I guess I've just been really, really lucky, and I know when the kids were younger, it was really a tightrope, and if one little thing went wrong, if the school called because I had to pick up a sick child, then everything went out the window. But I guess the other thing, I'm just been really lucky, because I'm a clinician, I can rearrange my time around the kids, and so I always, I did a canteen. I was always at school for reading, but I had a part-time nanny who really helped me, and I had a great mum who also helped, and of course I have to mention I have a fantastic husband who's supportive, and encourages me to do what I do. And I guess you'll have to ask my kids whether it's been successful or not. But I think they've turned out okay.
It sounds like it. So yeah, that's all we've got time for, unfortunately. I think we could keep talking for hours, but thank you so much, Rochelle, for sort of sharing, your impactful studies and some insights into how you've actually made it happen over an incredible career. So thank you very much.
Thanks, Kathy. It's been a pleasure.
And our next speaker is another very inspiring person. So Laureate Professor Claire Collins. Professor Collins is a laureate professor and internationally distinguished leader in nutrition and dietetics. And her research performance is in the top 1% of most cited scientists globally. Her research evaluates nutrition interventions based on life stage and chronic disease risk. And she's invented 2 personalised nutrition e-health tools, the Australian Eating Survey and the Healthy Eating Quiz. And these have had broad impact on improving eating patterns, diet-related health and well-being. And I actually subscribe to this myself, so I can personally attest to the impact that her work has made. It's fantastic to have evidence-based messages about nutrition. So welcome, Professor Collins.
Thank you, Professor Sherrington. Can you hear me okay?
Yes, that's perfect.
I have to tell you that I did it my way, and Frank Sinatra was absolutely right. But I'd like to acknowledge that I'm on a Wabakal country and acknowledge elders past, present and emerging, as well as all my collaborators and all the funders of my research. And I especially need to acknowledge where it all began. Number 9 was incubating in this photo. And I can remember asking my parents, can I do this? Can I do that? And my dad would always say, does it cost anything? Can you get yourself there? So I'd encourage you to read the My Way, and I've highlighted just a few key words in that song that really sum up the life of both a clinician and a researcher. So even though I grew up in Brisbane, doing it my way, I did end up doing dietetics at Sydney University after completing a science degree at Griffith Uni in Brisbane. I finished uni on the Friday and I got my first job at the Mater Hospital in Newcastle, a 5-month locum. Be careful when you accept a locum. It's now 40 plus years later. And I definitely did it my way in terms of that from 82 up until 99, I had a range of full and part-time dietitian's role. And a big part of that was that I had no family in Newcastle. My husband was Sydney, my family in Queensland. And so it was really up to the 2 of us. My husband had his own business. If he didn't work, we would starve. So I really needed to moderate the work that I did. But I also did locums for friends when they were having their babies. And I started my first ever media training in 1989 to try and improve my nutrition communication. But my main role, specialist role, was from 1986 to 2008. I was the dietitian to the Cystic Fibrosis Clinic in Newcastle. And just so we're all on the same page, CF is actually the most common genetic condition, affecting about 1 baby in 2,500. And it's a defect in chloride transport that means all your mucus secretions are sticky, your pancreatic enzymes are stuck. And when I graduated, life expectancy was between 12 to 15 years. And for those born in 2016, because of research, because of the new discoveries, it's now 56 years. The cystic fibrosis gene was identified in 89, and it was said 10 years to a cure. That was said 3 times. But after 30 years of research, essentially, there, for many defects, genetic defects, there's a cure. And I'm telling you that because that's why I jumped in when precision nutrition became a thing, because I saw that genetics really are so powerful and can be used in nutrition in the future. So when I graduated in 82, there was only one thing I was absolutely sure of, and that was that I would never, ever do research because I had not enjoyed it in my dietetic training. But after, being out, graduated and working in that clinic for about 5 years, I really wondered if my role mattered. Were we really helping the kids? Was it doing enough from a nutrition point of view? And I thought, if I can't show that it matters, then I need to get out of the way and let someone else take over. The clinic was supportive. My boss, Professor Richard Henry, was doing his PhD, and he said, you can find it out if you do research. And so began the life of a clinician researcher. I asked a PICO question, and I wanted to know, as part of cystic fibrosis team care, did the dietetic nutrition service lead to improved growth over time? Even got the T in on the end. And so by doing my PhD, mostly part-time, I switched to full-time when my youngest child went to school to write the thing up because we were all over it. But I was able to show, using really rudimentary growth charts and plotting the whole clinic on the same chart, how the cohort who had care from birth in our clinic marched through in a normal distribution, even though slightly skewed to lower percentiles, compared to historical cohorts. And it was actually the first time anyone in the world had shown that it was possible to get above the 50th percentile for height. So I did it my way. I never felt very brave, but there's something to be said for bravado. And we did it our way. It was a big sacrifice for the whole family to have one member doing a PhD. But the our way meant that I could pick the kids up from school, and then when they were back into bed, I could just tap away a little bit on the computer. And I used to promise myself just 30 minutes. And sometimes that was all it was, but sometimes it was a lot more than that. So coming back to my personal timeline, I got my PhD awarded in 1999. And at that stage, it was said, you have to go and work at the university. Well, fortunately, I got a job, a 50% job at the university, and I was a balanced academic in that role. So teaching, administration, and research. And I have to tell you, when I first went to the university as half-time, I felt like I was surviving. But I continued to work with the cystic fibrosis. That was really a passion. Mentor new dietitians in the cystic fibrosis interest group, which over the time had grown from about 5 members in 1999 to hundreds of members over 15 years. And we were able to demonstrate that we were improving the mean BMI percentile for children with cystic fibrosis in Australia. We also showed that we had the most dietitians in the world who'd had research higher degrees in this topic, and how that had grown over time. And we really loved this slide on my right, which showed the mean BMI percentile for Australia, the US, and the UK, and that we were performing above average in terms of improving growth of young people living with cystic fibrosis. But from 2010 on, I would have to say in the university world, I was now thriving. That's the year I got my first NH and MRC fellowship. I actually applied 5 years in a row before I got one. And this is the research to action plan that I use as a research fellow. We do a lot of evidence synthesis. We've published more than 100 systematic reviews. We dug in and did a lot of methodological work on methods to assess dietary intake using biomarkers. Then we did pilot studies and interventions and seek to translate those where we could to practice based on life stage and chronic conditions. And at the heart of it is still nutrition science communication. And like Rachel, I think a lot of that came from my work as a clinician, where you often found yourself translating complex medical things into plain language for families in busy clinics. So working with the media, I think, is something that really helps not just your patients, but helps the world value your research. This is a whole heap of media stuff that I've done over the years. And I've got to thank my profession for all the media training. And I was a spokesperson for 20 years for my profession, because I really think it helped with everything: writing grants more clearly, communicating to the public, communicating with patients, and actually listening and seeing what people value. And it actually in turn influenced my research. This is just some of the projects. The No Money, No Time that Kathy mentioned is a free website where basically we can have the final word. We don't have to worry about influencers. We can just put the evidence-based information on that website. This is some of our team thriving. I was really proud when we used to do that, you know, the ARC era assessments. We scored 5 in both of those campaigns. And when I graduated, I was the 12th dietitian in Australia ever to get a PhD. And now between us, I think we've graduated something like 60 dietitians with PhDs. So, and in my team, we do it our way. And this is a really important issue because my team is 99% women. And so I think by having a strong team who recognize the importance of maternity leave and still provides opportunities to women during that life stage, that we can collectively carry each other on so that the CV is still building while women are working part-time or actually on leave. So this is kind of how I would describe us. And we have our own food and nutrition research program, which is a node within the Hunter Medical Research Institute. So these are my take-home messages. My presentation is pretty short. Work smart, hard. So I think it's about quality, not quantity. I used to worry, oh, I'm not working full-time, people are going to think I'm slack, but it just was not realistic. But when I was working, I was trying to do things of value. Start small and dream big. And that's my especially my advice to women during those sleepless child rearing years. They go really fast, and you can chip away with small pots of money and then pick up the pace when you're able to come back into the workforce and in a full-time role. Find a mentor and be a mentor. Pay it forward. I think you make a really big impact through collaboration. And that was something that I wish I probably had have learned earlier, but now that I get my early career and mid-career research team members to do. Who can we connect? Okay, you can't travel. Can we invite them on a systematic review? Is there some online research that we could collaborate? And never give up. You know, I think we're usually around that, 10% success rate in grants. So I think that's really important. Just keep putting it in. If you don't put it in, you're definitely not getting the grant. And people sometimes get upset. Paper gets rejected, grant gets rejected. Someone says mean reviewer comments. And my philosophy is don't get mad, just get better. Because aiming to get better puts the focus back on you and what you can do rather than on plotting your revenge. And very important to celebrate your success. It doesn't come easily and it doesn't come all the time. But above all, do it your way. And like Frank Sinatra, after a long career now, I feel like I did face it all and I have stood tall and done it my way. And I'm going to leave you with the words so you can jump in there and see if any of those mean to you. Chart your own course. You all will have bitten off more you can chew. There's always doubt. You laugh and you cry, and you do have your share of losing. But after all, you're going to do it your way. Thank you.
Wow, that was fantastic. I'm inspired to do more. That's awesome. Thank you so much, Claire. So we've had a couple of questions come through. What do you think is the most challenging part of grant writing?
The challenging part? Gosh, it's hard to say. Probably for me personally, maybe the budget. But I think really it depends on the grant. Maybe writing a background or like a rationale that's really going to speak to the reviewers rather than just to yourself. I have to tell you that after my last NH and MRC fellowship, I have not gone straight through in the fellowships. I've spent time in the wilderness in between each. And when, because I was a near miss, the university let an external reviewer look at mine, and he told me it sucked. And it was really hard then to like pick yourself up. And it got me to brainstorm, what would I really do if I didn't care about what anyone think? And I thought, oh, pretty easy. That would be the precision, the genetics. But I had no track record, so I hadn't been game to put that in there. And then rewriting it agnostically, you know, and I think what I've learned from my grant failures is that if I just try not to be upset, but I try to listen to what they're saying, then I actually can sell it much better. So yeah, there's no easy part, I think, for writing a grant. It's always hard work.
That's amazing. Yeah. And I think that I often say exactly what you said, that if we don't have a go, then we certainly won't be successful. So,
yeah, that's exactly right.
Yeah, and I love that. Yeah, don't get mad, get better. So yeah, that's awesome. So how do you think clinicians and yeah, and also sorry, the question just disappeared. But there was a question about how you think clinicians can stay up to date with the latest research.
Yeah, well, I think subscribing to some of the journal updates really helps. And the other thing I do is I actually follow through Google Scholar some of the researchers who I know do really cutting edge stuff that I want to know. So then it pops into my inbox and I share those with members of the team. I think that's the key thing. Writing systematic reviews actually helps you. Volunteering to be on committees where clinical guidelines are writing, that forces you to be up to date as well. So I think it's whatever mix of things work for you and your team. It may be that your team does a journal club where you're updating each other.
Yeah, excellent. And we've also had a comment here saying someone feeling very inspired, and thank you for sharing your story and achievements. But we've got an actual content question. So what were some of the things that improved the BMI of children with CF, and how did you discover what they were?
A collaboration. So a shout out to my colleague, Professor Helen Truby, and I, who were both started our PhDs at the same time in nutrition in cystic fibrosis. And she was at Melbourne Children's and I was at the Newcastle at the John Hunter by then. And Helen bravely asked our profession if we could have an interest group. This is all before the internet for young people who mightn't understand that. And everything was state-based. And because there was only 5 of us, they actually agreed. So it was phone hookups. They let us sneak in the one cystic fibrosis dietitian from New Zealand, so long as we didn't tell anybody, because we were a national body. And it was really that. We did a survey of practice. We looked at what's the area where no one's agreeing. It was pancreatic enzyme replacement. We started clinical audits. We all then contributed to the national clinical audits that the clinics were contributing to. We monitored our progress, and then we saw that we could go for nutrition guidelines in cystic fibrosis. Lots and lots of mentoring, but everyone is on the same page. And I would encourage people to take that same collaborative national or even international approach.
Amazing. And yeah, obviously that using data to monitor practice.
Clinical data.
Is it harder to be competitive for grants post-PhD if you're also working clinically for people who are then spending less time on research?
No, absolutely not. The MRFF scheme is made for clinicians. I think it's about making the collaborations, because you have access to all of the patients, most likely, the people at the university, probably looking for clinical partners just like you. So I think make a time to have a coffee with the people that you want to work with. And like I said, it really is about the team. When you're reviewing grants, you're looking to see that there's the right mix of the team. So there's a match made in heaven. Just go and find your academic partner who hasn't got access to patients, and you'll be off to a great start.
And probably a last question. Do you have any advice about how to get involved with science communication, or thoughts around best working with the media?
Yeah, I absolutely do. And first of all, go to your institution, whether it's a university or a health service. There is a media team there, and ask them to put on a workshop. If your institution subscribes, which they most likely do, to the conversation, they can actually bring people to a university to talk about how to write for them. So if you're feeling brave when you publish a paper, go to the media people at your institution and ask them to do a media release. And then each time you talk to a journalist, put your little black book together of your media contacts, and then you'll be able to work with those people again in the future. That's a few key points. And just do every training opportunity, whether it's through the academy or your university or your professional society.
Fantastic. I liked how you said that you felt that your sort of media training actually helped your communication for grant writing as well. So I think,
yeah, definitely. You learn to be more succinct, and importantly, you learn to listen to what the listeners care about.
Amazing. Thank you so much, Claire. That was very inspiring. We're very grateful to have had you share your expertise and great tips. So thank you very much. We're now moving on to our panel session. And I'm going to hand over to Professor Kim Bennell, AM, to facilitate this session. Professor Bennell is Melbourne Laureate Professor in the Department of Physiotherapy at the University of Melbourne, and there she leads the Centre for Health, Exercise and Sports Medicine. Her research focuses on non-drug, non-surgical management of hip and knee osteoarthritis, as well as ways to address evidence practice gaps around the uptake of pain management and lifestyle interventions by clinicians and patients. Thank you, Kim. I'll leave it to you to introduce our fabulous panel.
Thanks very much, Kathy, and fantastic talks from Rochelle and Claire. Thanks so much for those. And it does give me great pleasure to announce three very esteemed speakers for our panel. We have Professor Caleb Ferguson, who is an NHMRC Emerging Leadership Fellow and Director of the Centre for Chronic and Complex Care Research at Blacktown Hospital. He is a stroke nurse and also leads a research program in chronic care focused on cardiovascular disease and frailty. So welcome, Caleb. Our next panel member is Professor Gemma Sharp. She is head of the Body Image and Eating Disorders Research Program at the University of Queensland. She's a multidisciplinary clinician-scientist with a Master of Science in Oncology from the University of Cambridge and a PhD in Clinical Psychology from Flinders University. She also leads her own private psychology practice and is the founding director of the Consortium for Research in Eating Disorders. Welcome, Gemma. And our third panel member is Professor Gary Whittert, who is Professor of Medicine and Director of the Freemason Centre for Male Health and Wellbeing at the University of Adelaide and Samari, and a senior, I haven't got the rest of my introduction page, but you can tell me a little the rest of your story, Gary, so welcome. So
thank you.
First, I think before everyone can put their questions in Slido, I do have some questions, but it'd be great if people can put their questions and we can get to some of those. But before we start, it'd be just great if each of you could just give a little 1 or 2 minutes about yourself, your clinical research journey to date. So we might start with you, Gary, since I missed half of your intro.
Thank you very much, Kim, and thank you to the association for the invitation to be here. The story started when I was in South Africa, where I trained, and then subsequently came to New Zealand, where I worked in general practice with very little intention of following an academic career at all. But I subsequently left that and went into physician training in New Zealand, and then subsequently a higher degree, which I was fortunate to combine with my advanced training, and a model that has inspired me to set something similar up in Adelaide. I was then very lucky to spend some time in the United States, where I learned something about molecular biology and molecular physiology, and then subsequently came to Australia, and have been in Adelaide for 30 years, where I've been, I think, very fortunate to have the opportunity to combine many different research modalities, including epidemiology, basic science, clinical research, and to do that across a number of areas, although the core of it is obesity and chronic disease.
Great, thanks for that. Gemma.
Thank you so much, Kim, for the introduction, and it's really wonderful to be here. And I wanted to say, Gary, Adelaide is my hometown, so I feel like you settled in the best place in Australia.
I think so
So
too. Thank you.
Yay, Adelaide. Um, so I was very fortunate to start out life as a lab scientist and molecular biologist, as Gary mentioned. So I was at the bench doing all those fun experiments. But when I got to Cambridge, our research institute was based next to Addenbrooke's Hospital, which is a very famous hospital in Cambridge. And I was allowed to attend the clinical meetings where they discussed patients' presentations and how they were going to treat them. And I just got so inspired by the clinical aspect. I was like, I really want to combine research and clinical work. And in psychology, we have what's called the scientist practitioner model. So all of us have to be trained clinically as well as in research at a postgraduate level. And so I suppose the rest is kind of history, but in terms of my specialist areas, I absolutely love working in body image, eating and weight disorders because I suppose they're very misunderstood, and they have that physical and mental health combination that I absolutely adore. So that's my journey. Thank you, Kim.
That's great. And Caleb?
Yes, I'm originally from Scotland, and I moved here about 20 years ago. And one of my first positions was in the neuroscience unit in one of the hospitals in Sydney. And I've worked in stroke for quite a while after then. And I guess when I saw patients in the stroke unit probably about 20 years ago, there wasn't so much that we could do for them. There wasn't as advanced therapies, both in the sort of medical treatment, but also rehab and in the acute care setting. So it was pretty depressing then as well. But in terms of working in the stroke unit, but I was fortunate to meet a mentor who was researching in cardiovascular disease and did my PhD when I was teaching at UTS and did that at St Vincent's Hospital in the heart failure and atrial fibrillation area and cardiovascular disease. And after my PhD, I was really fortunate to take up a joint appointment between Western Sydney Local Health District and then the Western Sydney University as well. And I've had some funding to support my career from both the Heart Foundation and now the NHMRC to really allow me in the last sort of 10 years postdoc to expand and broaden a bit more from being quite specific around heart failure and AF, and really broaden into sort of the chronic disease management models, in particular frailty as well. And so now leading a program of research here at Blacktown in frailty in older adults, in particular interest is cardiovascular disease in that area as well. But thanks so much for having me as well. Thank you.
That's great, great mix of panel members here. So there's a couple of questions here, and one that's sort of interesting, I think. A few people have liked it. What do you dislike most about your career? So perhaps, Caleb, you might want to start with that. But it's interesting, we've been talking about the good parts and so forth, but what things have you found that haven't been as enjoyable, let's say?
Yeah, I think often it's great to straddle across two institutions, the health service and the university, but and I guess you're privileged to really serve in those two organizations and to be exposed to patients and clinicians and have that academic expertise at the university as well. But sometimes what drains me is the bureaucracy of both of the organizations, and double the paperwork, double the mandatory training, double everything in terms of administration. So I think it's that sort of mundane sort of bureaucracy of the two organizations, but I don't think I'd have it any other way, because it's just an absolute privilege to be able to sit in the hospital and to pop upstairs and see patients. Yeah.
Is it funny? I've heard that from someone else, said exactly the same thing about the two lots of emails and the two lots of all of those. So how about Gemma? Do you have anything to add to that? And
I mean, I absolutely second Caleb there on all points, that it is an absolute honor and privilege to get to do what we do, but there is a lot of administration. I think what sometimes bugs me a bit, and again, I'm very lucky to be in this position, is just I can't always pursue all the research and clinical ideas I want to. There's only so much time and so much capacity for the team. And I think if my team hear me say, oh, just one more project, they'll probably scream and run away. So it's about, I suppose, absolutely making sure you do the core work and do it really, really well.
Yes, prioritising, I think is what you're saying, being strategic rather than taking up all the opportunities. So that's great. How about you, Gary? Do you have anything that you sort of dislike about your career, or things that you think you've identified that you've maybe tried to change and you make them more workable?
Well, it's an enormous privilege to be able to choose what you want to study, to be able to think of a question and then be able to answer it. And I think for those of us who do this, we're absolutely driven by the need to answer questions. And so I think one of the problems with that is the tendency to try and answer too many questions in too many different areas. That issue aside, I agree with Caleb that I think the biggest difficulty, if you like, or thing I like least about this is the bureaucracy, the multiple forms, the necessity for all the steps in compliance, while absolutely required and agree that it has to be done. It's still a burden to do those things. And I have to say, I don't particularly like writing grants. It's a necessity. I'd much rather be writing papers. But, you know, many things in many different jobs and careers go with the territory. And so those are the things that just go with the territory, I guess.
No, that's great. And I think, as you said, any strategies that can be harmonised across those institutions might be welcomed. So thank you for those. So another question is around, when you are working sort of clinically and research, do you receive or do you have dedicated research time, or if not, how do you fit it in with your clinical demands, and you know, what strategies do you have to make sure that you've got enough time to do all of that? So maybe we'll start with you then, Gary.
So I think firstly, I'm in a very fortunate position in that I have a university position, not a hospital position, and that quarantines me from excessive clinical demands other than what I might choose to impose for myself. I think that critical to what I do as a clinician-scientist is seeing patients. So that helps me to understand the sort of questions that I need to ask and to see how work can be translated into delivering better care. But it is a challenge. It's two days out of the week that are consumed with clinical care, reducing the amount of research time. And the necessity is, as I think Claire Collins put it, was to work smarter and to focus on what is absolutely key, and to learn how to delegate and collaborate with other people so that you reduce the burden on yourself.
Thanks. Gemma?
I think Gary gave some really excellent points, and then contrasting like hospital position versus other clinical roles, I found it quite challenging to manage university and hospital appointments, even though literally I was next door. I only had to walk about 100 meters. Nowadays, I think I'm very grateful to telehealth for helping me to maintain a higher clinical load. So I'm able to fortunately set my times because of my research appointment at UQ. My clinical work is done outside of that, but because of telehealth and technology, it makes it a lot easier. And I think the patients really appreciate it too. I know that not everyone can do that, but certainly in my kind of area, it has been fantastic for combining research and clinical.
Great. Caleb, do you have any sort of, how's it worked for you?
Yeah, I guess just reflecting on the balance, I think one of the things that I'm really privileged to hold an NHMRC fellowship that's really been quite helpful to quarantine a lot of my time and responsibilities to really focus in on growth in the research area and focus on a program of research and developing that and developing a team here at Blacktown. So at the moment I've not got any direct clinical duties in care provision, but that said, I can pop upstairs to the rehab and aged care department and see patients, which is fabulous. So I think fellowships, whilst really competitive, really do allow that time to focus in and develop that postgraduate postdoctoral program of research as well. I guess also I'm very aware of where I spend time, and so I try to spend most of my time here in the hospital and really love that engagement with clinicians and with patients. But I do try to spend maybe a day a week or a day a fortnight at the uni as well, just to sort of make sure that I do have that engagement and networking with colleagues there as well. Yeah.
Right, thank you. So I might start with Gary for this one, but Gary, looking back over your research journey, is there anything you'd do differently, and if so, what?
Yeah, I would focus more. While I said that something I've enjoyed and something I found rewarding was being able to do research in a multitude of different areas. I think I would have been better off in a multitude of ways if I'd have focused more on one thing. So I'm not sorry I did what I did, but if I did it over, I would probably do it that way. We've frozen.
I think we may have lost Kim there.
Yeah.
She did warn that she may have some unstable internet, so I'll come in. Caleb, would you like to comment on that? Yeah, whether you would have done anything differently?
Yeah, I think Gary's point around focus is quite important. I've also struggled with this concept of having a very narrow, defined program of research versus sort of not staying in your lane, as sort of Claire said. But also being a bit more broad and how that maybe broadens over your career as well. And I think, to have impact, you've really got to focus in on one particular thing. But I also think it's nice to have a few sort of irons in the fire and have a few options that are tangential and can help you sort of broaden out as time goes on. But I agree. I think sort of keeping focused is really important on the big issues, and also that importance of engaging others in different disciplines with different expertise to really tackle the big problems. So I think when we think about multidisciplinary collaboration and teams, I often think, the colleague who's a pharmacist or a cardiologist and bringing in the different disciplinary expertise. But I also think for some of those wicked problems that we look at in health services research as well, really sort of bringing in very different and diverse expertise and also the voice of consumers with lived experience as well.
Very wise words. Gemma, would you like to comment?
Sure, thanks, Kathy. So I think wholeheartedly support Gary and Caleb's comments. I think for me it would be, I wish I'd become a clinician sooner. So I did do all that lab training and then became a clinician a little bit later in life. But I mean, potentially I might have had a different journey to become a clinician if that hadn't happened. And I agree with Caleb. I think I was very fortunate to be in a field that had very early adoption of that lived experience co-design or patient voice. But I really wish I was doing it at the earliest stages of my research career. I just know my research would have been more impactful and more helpful, but I'm grateful to have it as a core theme now.
Amazing. We've now got a question about the challenges of multidisciplinary work that's come up. You know, you've all sort of talked about that, but would any of you like to comment on any kind of challenges that you've experienced trying to bring together a team of people who might view the world differently? And I guess any tips for overcoming those challenges? Caleb's smiling. Let's go to him first, and then Gemma, who's nodding.
Well, this is a tricky question, Kathy. I think that there's a rule, you know, work with good people and work with nice people as well. Making sure that you sort of working with big teams is often challenging around managing, particularly ego in academia and in research. And trying to sort of keep the peace as the lead investigator, or give everyone, you know, time to express their views, and managing sort of conflict within different viewpoints within a team can sometimes be quite challenging. So I think developing those skills to allow those people to have a voice in how you manage conflict within a large team as well. But it's so value adding to hear others' perspectives, that, you know, to have that sort of aha moment that you've never really seen or thought of that perspective before, when someone brings that to the team is really, really valuable. Yeah.
And I guess, you know, working in a multidisciplinary way could be something that we can bring, you know, more easily as health professionals, perhaps, than as other types of researchers. Gemma, would you like to comment? And I see Kim seems to have returned. So we're
Welcome
just
back,
talking
Kim.
about challenges with engaging with a multidisciplinary team. And Caleb's given some wise words, and then Gemma's about to, and then we'll throw to Gary.
I think, like Kim has demonstrated, the challenges of a multidisciplinary Zoom, and I have that all the time as well. I wholeheartedly support Caleb's comments there about the value add is far more than any disadvantage. And I think potentially what I had going for me was, in eating disorders, we are always in multidisciplinary teams. So you have doctor, psychiatrist, dietitian, psychologist, social worker. So kind of from my earliest training, I knew about the value of all the different voices, but I'm certainly used to being disagreed with in when I'm leading these large teams. And I suppose my advice is to always bring it back to that shared value. What is it that you're actually trying to achieve together? Because sometimes that gets lost in the disagreements, can't see the wood for the trees, but ultimately you've all come together, for example, to try and cure eating disorders or cure stroke, whatever it is. That's the core value that you all have in common. And I find that to be very grounding when I get people to sort of reflect on that, and we can usually navigate most things after that.
Amazing. Over to you, Gary, and then I'll hand back to Kim.
Yeah, I think it's been one of the most rewarding components of both my clinical and research career, and some of the things I've learned have been from colleagues, giving me both a different perspective and a different direction to follow at times. And one thing I would say to people who work in basic science is find clinical colleagues to work with, and do that as early as possible, because it helps your perspective. So I don't think it poses much difficulty in comparison to the reward and the benefits that accrue from doing so. And I think, of course, we should all be doing that, and I include consumers in that, because we learn an enormous amount from the people that we aim to help in the community, and they're very willing to help us.
Thanks, Kathy. Let's take two, although it does say my internet's a bit unstable, so I apologise, and you might have to step back in, Kathy. But yes, it shows you the challenges of technology, doesn't it? So there's obviously a few people on the call here today who have non-clinical backgrounds, a bit probably like you, Gemma, who are interested in how they may be able to, what are the pathways to becoming a clinical researcher? If you're a higher degree student, you've got an undergrad in biomedical science, but you haven't got a background, a clinical background or a clinical experience, but you want to get into that area. So, what would you recommend in that way?
So yeah, I did train as a biomed scientist first, and then went back, and fortunately, and I think a lot of courses have this as sort of a kind of a bridging course, so you don't have to go back to square one, in order to train again. So like the postgraduate programs and things like that, I was lucky enough to do that, and I think I honestly think sometimes we are at a bit of an advantage, that we are a bit have a few more years to us, a bit more life experience. I know they certainly look for that in psychology, people to be psychologists. So I would just say it's never too late if you're very determined to do this, and absolutely that universities have pathways for you to go back and retrain, and it's not necessarily a disadvantage to. In fact, I found it to be a great advantage for me to have had my lab science background.
That's great. And do you also feel, others on the panel, that you don't necessarily have to go and do, I mean, that might be one path, but we have a lot of researchers in our team who don't have clinical backgrounds, but I think the advantage of being in a multidisciplinary team is that you can work with clinicians, have consumers on board that bring that, so you can all bring different aspects to it. So you get that clinical expertise and from others, and you obviously pick it up along the way. Is that sort of, the others' experience as well, and yours?
Yeah, I have a couple of postdoc fellows. Two are nurses and two are from medical science background, and I think just the two that aren't from a nursing background are, they bring different values, and they see the world a bit differently. But it's great that the value add to the team that they have. And I think just being embedded within the health system and based within the clinical setting changes a lot of their perspectives on things and their interactions with others, and sort of, as I said, how they view the world. But I think the just how they contribute to the team and the skills and expertise and knowledge that they also contribute, and they learn so much all from each other as part of the team. So I also think it's not, to me, yeah, there is the option to go back and retrain or to go and do another degree, but I also think it's how do we also engage other expertise in the clinical setting to solve some of the problems that we face. Yeah.
I think that's great. So some few other interesting questions in here. We have one around, what advice would you give then to first year students who are aspiring to work in the broad field of healthcare? Who would like to?
Are we talking about healthcare in a research sense or in a clinical sense?
I think in the research sense. Well, given that this is a research talk here, I think getting into the research field.
Well, I think most universities, if people are engaged in health-related undergraduate degrees, provide opportunities to interact with research groups with a clinical focus. Now that opportunity is very broad. It might be in the social sciences, it might be in nursing, it might be in psychology, it might be in medicine and different specialties of medicine. So I think it's around going to talk to people in those groups, listening when they talk, seeing what they do, and looking for the opportunities to engage. Many universities and research groups offer vacation scholarships, which are a great opportunity to dip your toe in. There are often elective research projects, which is an opportunity to dip your toe in, or you can just rock up and volunteer to do stuff, which is another way to dip your toe in. So I think if people are enthused by research, is the only way to know is to go and do it and get involved and experience, what it's like on the ground and how people work together.
Gemma, do you have some things to add from your perspective?
I think Gary's done a great job there, and I'm seeing more and more internships built into undergraduate programs to give students that opportunity, whether it be with like an industry or a not-for-profit partner. So it's not just sort of the university type of research. They can have those experiences outside. And I think I always sort of ask the question of, you know, what brought you to decide on this degree in the first place? And because that's, I think, reflecting on one's motivations is, and what gives them meaning, what gives them value, will really help guide them moving forward in their decision making.
Thank you. Caleb?
Just to sort of second Gary's suggestion there around engagement in the internship opportunities. I think summer scholar programs, we've had many a student that has been exposed, undergraduate students that are exposed because they've had the opportunity to do summer scholar programs or internships over that summer break in the research setting, and that might be undertaking some skills around, you know, data entry or even a small project where they produce a publication at the end. But they're really nice on-ramps into honours degrees, MPhils and PhD programs, and I've seen quite a lot of people really succeed in that pathway, having that really early engagement in immersion, I guess, in the research setting over that summer scholar program. So I can't plug them enough, and they're great opportunities if people have the chance. Yeah.
Thanks for that. And yes, I know in our degree there is, you know, electives, and so you can choose to do, you know, 4-week research electives and other opportunities. So I think that's great. So there's another specific question that people have wanting to ask about. We know that grant writing is a huge part of research career, and someone mentioned that was their least probably favourite, Gary, I think. What do you think is the most challenging part then of grant writing? So I might start with you, Gary. What you said you weren't a big fan of it, whereas some people love writing grants. What do you think is the most challenging part then for you? And maybe some strategies around how you might go about that.
Well, I'll give you the last part of the question first, is find someone better than you to work with. So I think the difficulty for me anyway is communicating what I sometimes might view as a complex idea with simplicity. And I think Claire put it beautifully in her talk, which was taking a step back and seeing how you can communicate something with absolute clarity so that people see it the way you see it, which is the way you meant it to be seen, not the way that it is seen, which is often not the way you wanted it to be seen. And I think that's something that's very difficult to do, and for some of us entirely dependent on the input of others. And it's important to recognize that, and I think to recognize it early. The other point is that I think that we can learn to do these things better, and we only learn to do them by trying and failing. It's like learning to ride a bicycle. Falling off is very painful and humiliating, but you have to get back on and try. And if you don't quite have the motor skills for the bicycle, then you have to try twice as hard, but eventually you get there.
Yes, that's great. I totally agree. You get a bit of a thick skin, don't you? Because you realise that, you know, we are all going to spend a lot of effort try to get grants, but not necessarily get them, and we have to keep persisting. But Gemma, do you have some other insights and suggestions?
Yeah, I think so when I'm leading particularly the bigger grants, I always have kind of my team leads who are writing sort of certain sections. I might be overseeing it, but I'm always getting the advice and input from my excellent colleagues as to how to make it all hang together. I think it was Claire as well who said budgets are tricky. I agree with that, but they can be done, and I think it is about sort of sometimes we have to remind people there's only a certain amount of money, but this can be a platform for future research, that this is hopefully the beginning of a chain of success. Although I think, Gary, I've fallen off so many bikes now, but hopefully I I stay on one for a while. They're my comments. Thanks, Kim.
Thanks. Caleb?
I think it took me a while to realize that you need to sort of have a bank of grants in the pipeline as an ECR, just as important as the the journal articles as outputs, and keeping those ideas sort of progressing and moving along. And I think there's a hard way to write a grant just in isolation and struggling along by yourself. And I'm really quite surprised and amazed at the generosity of others when you pull in all your favors, as I like to say, when you're really sort of pushed to the limits, but you call on your friends, to your trusted critical friends, to give you some feedback, and just how generous people are, whether or not it's providing some stats advice or implementation advice or whatever it might be. Just, I think, sort of not being afraid to tap on colleagues for advice, and really getting getting a sort of fresh set of eyes on a grant can be very helpful. Just, it's someone else seeing this for the first time as well. So I think really that importance of working within a team as well, and having all the different expertise is part of that is really important. And also the sort of process around sort of incubation, if you like. And I've heard other colleagues call this sort of a pre-mortem sort of approach of, here's my idea, this is what I have, and what could go wrong, or what's the matter with this proposal, and really pulling that to parts, because you imagine that it goes to the peer review panel, and that is someone's job. So I think really that importance, really highlighting the importance of the team approach, and really not being afraid to ask for help from other colleagues, and to draw on other expertise, because doing it alone is really difficult, and often very unsuccessful as well.
No, I think you've all picked up some really good points there, and around getting feedback from others, and along the way. And also, I think really, as you said, good to get feedback from others not in your field, because the grant reviewers are likely to be people that don't have anything to do with your field. So, is it understood by someone that's not in your field? So that can be really helpful as well. So I think you've given some really good sort of tips there around grant writing, and you've brought up a pre-mortem, and I think also the post-mortem is often a really good idea when you don't get the grants, and oftentimes you don't get a lot of reviewers' comments, but you can sort of sit down and go, where do we think perhaps we could improve, and get feedback from that perspective, because as you said, you're always trying to improve. So thank you for those. That's great. I think that another question would be around, what would be your one top tip, piece of advice to someone embarking on a clinical academic career? And I think Gary said about, focusing, being a bit more strategic, and any other sort of top tips that you might have for the ones sort of embarking on the career. Might start with you, Caleb. Oh, sorry, Gary. Yep, great.
Sorry, I was going to say, find a topic that you're passionate about, and find really good people to work with. And the third thing I would say is you get one initial shot at a fantastic education. So find the best possible place you can go to get that education. Work with the best possible people. Ask as many questions as you can, and then go with that and see where it leads.
Now that's a really good point, because a lot of it's out of your control, isn't it? And if you go somewhere, they will give you the opportunities and support you and push you forward. So I think that's really very important. Gemma.
Thanks so much, Kim. And just confirming, advice for early career folk. Yeah,
yes,
I mean,
starting on a career, yeah, that's right.
Gosh, I'd say good choice. This is a very exciting career. I think what I would say as well is don't expect it to be in any way linear or what you expect it to be. That sometimes opportunities arise and you've just got to grab them. I think, yeah, sometimes it is a bit momentum driven, and almost don't plan too much, because it will likely change, and just be flexible and open to opportunities.
I think that's a really good point, because on one hand you need to try and be strategic, but on the other hand opportunities arise, and if you don't take them you don't necessarily arrive at it. So I think that's a good point, that sort of balancing of those two as well. Caleb.
Just again, wanting to agree with Gary around the researching things that are big and important and wicked and complex problems that affect a lot of people, that cost a lot of money and impact patients a lot. And there's many of these problems, and these are things that will be around for a long career. And so I think, you know, really thinking about the thing that you want to research. But I think the other point that I wanted to make is just around mentorship. And it took me a while to realize, you know, you need more than one mentor. You need sort of, you know, a little sort of uh, crowd of sort of guardian angels, if you like, who are happy to sponsor you more so than mentor you. And you can tap into these at any time. And as your career goes on, you might go to one for advice about something and to another who's got, you know, maybe better advice in this area than that area. And so I think having multiple mentors is really important, seeking out some really wise counsel and advice about, you know, the opportunities that arise. And I guess there's always that thing about saying no as well, so knowing when not to do something, because you do have, often a lot of opportunities are presented, but deciding on the things that you don't do and not to take up as well. Yeah.
I think that's great. You've brought up some really good points there. I think one about the research area that you're doing is really, really important. And, you know I did for my PhD one thing, but then I went across and did a whole different area because I decided that wasn't going to be a good area. So you're not fixed. Just because you've done one thing doesn't mean that's what you have to do for the rest of your career. And I think you've also brought up really good points about mentors, and no one person can necessarily, you know, give you everything that you need. And so having different people is a really, you know, really good opportunity. So seeking people out across different areas that you need is really important. So thank you. That's great. So I think that might be a really good place to end, but just like to thank all of our wonderful panel members who I think had a lot of pearls of wisdom to share with us, lots of experience, and across, I think, highlighting that multidisciplinary across different areas. So thank you so much for giving up your time and speaking to us. So I might pass across now to Kathy to end this now. Thank you.
Absolutely. Thank you so much, Kim. And thank you, Caleb, Gemma and Gary for those wonderful insights. And just to note also, Gary is also a fellow of the Academy too. We appreciate you joining us today, and we also really thank Rochelle and Claire for their earlier fabulous talks. We'd just like to acknowledge our partners once again for their generosity and support of this program. And we'd also like your feedback. And so please scan the QR code on the screen to help us shape the future of these events. And thanks once again, everyone, for joining us today. We hope you found it inspiring as I have, and we can't wait to see where your research journey will take you. Thanks again. Bye-bye.